specific to the actual anatomic part. And then we also have the large gonad shield, right? The large aprons.
Sir, can I have a question, sir?
Yes.
When for gonads for female would be the uterus and or the ovaries, sir?
So ovaries, yes.
Only the ovaries. And for males it would be the
testes, the
testes.
testicles.
Or it's just the reproductive organs, sir?
Yes, that's correct.
So gonads defined would be reproductive organs.
The reproductive organs, yes.
Oh, I see. Thank you, sir.
So, see, you've got the shield here. Over here, you see there's this really fancy shield which actually hangs down from the tube. Right, so it creates this shadow here in the gonadal region. But overall, the key point is that do try and shield the gonads whenever possible. Now, I will take this time to give you all a heads up. A lot of times, after people go from students to techs, they begin to try and take shortcuts. One of the shortcuts that you may see out at the clinical sites in the fall is that some techs will not shield their patients. Okay? Whether it's for speed or whether it's just because they don't want to put in the effort, I can't say. But you will see techs that do not use shields on patients. Do not be like those techs. If you are working with such a tech and they are letting you position the patient, use a shield. Even if the tech says, no, you don't need to worry about that, use a shield. Okay? You are a student. As a student, your goal should be to build good habits during these 2 years. That way, these habits will carry over when you become a tech. Okay? As a tech, I can't control what you do, but as a student, I am telling you, make sure that you use a shield. Okay? IR placement. So we kind of covered this in lab. So how do you place your image receptors? Well, there are 3 general positions. We have lengthwise, also known as portrait. Take the long axis of the IR, put it along the long axis of the patient portrait. We have crosswise, also known as landscape. Long axis of the IR, short axis of the patient, right? Goes across. And then we have diagonal, which is something like this. Right? So you go across opposite corners. So you will see all 3 of these IR positions. So it is important that you know their names. That way, in lab, if I ask you to put the IR lengthwise, you automatically know to do this. If I tell you to put it crosswise, you automatically know to put it like this, okay? It is important that you know the names. It's also important that you know both names because I usually end up just saying the first one which comes to mind. Sometimes it will be lengthwise, sometimes it will be portrait. Just depends on my mood. So you do need to know both. You will hear text use both. Some text will use lengthwise, some text will use portrait. It all just depends on when they got their education. Older text will usually use lengthwise, newer text will usually use portrait. Great. Remember, this is based on the long axis of the body. So, if my arm's out like this, and the cassette is like this, is this lengthwise or is this crosswise?
Crosswise.
It looks crosswise to you, doesn't it?
Sure.
But where's the long axis of my arm?
This is the long.
Like this, right? This is the long axis of my arm. So really, this is portrait to my arm as the patient, even though this looks crosswise to you as the technologist. Does that make sense? So base it off the long axis of the body.
So for like a rule of thumb, things that are more distal to the body are considered like portrait, typically.
So
Distal being like digits or things that are like different, far away.
So yes, most things, most extremities will end up being portrait.
Okay.
Most things in general will end up being portrait or lengthwise. Okay? There are some exceptions, okay? And you will see those exceptions in your book and in lab. We will make sure to mention them. But yes, normally, if you had to just randomly guess whether it's lengthwise or crosswise, usually it's going to be lengthwise. But just look at your anatomy. Usually, it's going to make sense based on your anatomy. Right, so, this one here, lengthwise, right? Because long axis of the body, long axis of the IR. Over here, this is crosswise, right? Long axis of the body, but long axis of the IR, right? They're no longer the same. And then this is diagonal. So in this case, we have the cassette from corner to opposite corner, right? We turn it diagonally in order to fit the whole leg on it. So that is one situation where you will see a diagonal IR placement. Okay, central ray direction. So remember the central ray, right, that crosshair coming out of the tube. This is always centered to your IR. Unless you're purposefully using only part of the IR, which really does not happen anymore nowadays. So your central ray should always be centered to your IR. Usually your goal is for the central ray to be perpendicular to both your part and your IR to minimize distortion. For example, when you are out taking pictures of your friends, right? Or when we do class pictures, like you did on Wednesday. When we took the pictures, did we take it from in front of you? Or were we taking it from an angle? Or were we taking it like this? How did we take the pictures?
From the front.
Straight forwards, right? Why? Because that minimizes distortion. Right? We're not looking at it from a strange angle. We're not going to stretch things out. We're not going to make things look short. So always be perpendicular to your part and your IR unless stated otherwise. There will be some exceptions. You will learn what those exceptions are. Okay. Sometimes we will need to angle the central ray. The purpose of angling the central ray could be one of many. For example, sometimes we angle the central ray to avoid superimposition of structures. Superimposition is a very fancy way to say overlap. We don't want to overlap things, so we angle. Another reason why we might angle is to straighten out a curved structure. Okay. Something might be curved at an angle. We will put our central ray at an angle to match it. That way it now looks straight instead of curved. Sometimes we have joint spaces which are at an angle. We want to open up the joint space. We want to be able to see through the joint space. And because you've got bone, and the joint space is the gap in between the bones. We want to make sure we can see the gap. Because there are some diseases, there are some pathologies which affect this gap in the joints. And the only way to see those pathologies is to make sure that we are properly positioned. So if you don't see the gap, then you know maybe the patient has arthritis. Right? The joint space has worn away. You don't want to be missing the joint space and be unsure whether it's arthritis or I just positioned the patient poorly. So that is why we angle. And then sometimes we angle because we want to avoid distortion of an angled structure. So not all things in the body are gonna be nice and flat. Some things are at angles. And so we angle to straighten them out, keep them from looking strange on the image. So, reasons to angle. Yes.
So if one were to take a picture of, or to angle something of, let's say, the ribs, which is curved and like superimposing in some areas, you would like have an upwards angle, a downwards angle, like does that?
Great question. So in the case of the ribs, because they are curved, instead of angling the central ray, what we actually do is we angle the patient. So instead of just having them straight on and we shoot the ribs, we turn them at an angle like this,
Okay.
to kind of straighten out that curve on one side or the other.
And it gets the through and through the complete shape.
Yes, you do go through all sides there. So some examples of when we do angle though. For example, if you look at the neck, right? If you look at my neck from the side, right? My neck is not straight up and down. My neck is curved like this. So the bones in my neck don't look like this, right? The bones in my neck look kind of like this. They're angled. If I want to see this gap, I also need to angle to go through the gap. I have my foot, right? My foot is not perfectly flat, right? It has an arch. The bones of the foot kind of angle like this. So if I want to get these bones looking straight, I also need to throw on an angle for my foot. So those are some examples of when you would want to use an angle with your central ray. And so as you go through these chapters and you start learning about the chest and the abdomen and the extremities, you will learn positions where you need to angle. You will learn positions where you need it perpendicular. Right? And you will need to memorize these. You will need to memorize these.
So,
Yes.
so when we say angle, we are talking about the patient, or it could be both.
So
Angle the patient or angle the ray?
So normally with the patient, we do not angle the patient.
That's-
Normally with the patient, the only thing we can do is rotate the patient. We can turn them one way, turn them the other way. Right? With the tube, what we are mainly going to do is angle. Remember, angle is that black button on the tube. So when we talk about patients, you're usually going to hear us talk about rotate the patient. Rotate the patient 15 degrees. Rotate the patient 45 degrees. When you hear us talk about the tube, you're usually going to hear the word angle. Angle your tube 10 degrees. Angle your tube 25 degrees. All right, any other questions? SID. So we did go over SID in lab, correct?
Yes.
What are the two SIDs we normally use?
72 and 40.
Great, 72 and 40. So, as a refresher, SID is the distance from the X-ray tube, which is the source, to the IR, which is our image receptor. Okay? Got a fancy word here, anode. Don't worry about that right now. We'll get to that at the beginning of the fall semester, when you learn about what's actually inside that X-ray tube. Okay, so source to image receptor distance is abbreviated SID, for source, image, and distance. This is important because it affects a lot of different things. For example, it affects your image by determining whether or not you have magnification. The closer your tube is to the patient, the more magnification you will have. The farther away the tube is, the less magnification. The more real size your image will look. Spatial resolution. How well you can see fine details in the image. The closer you are, the closer your SID is, the lower the spatial resolution you have. Increasing the SID increases spatial resolution. It makes your image look more sharp, less blurry. And then patient dose. If you decrease your SID, small SID, you decrease your patient dose. If you increase your SID, you increase. No, I'm sorry, backwards. If you get closer, you increase patient dose. If you get farther, you decrease patient dose. Sorry about that. So, SID is important because it does affect those three things, among many. SID can also affect what kind of energies you choose for your X-ray beam. SID can affect which grid you choose to put on top of your image receptor. And so SID is very, very important. Okay. So
just to, if you decrease the patient dose, you're increasing the, if you decrease the distance, you're increasing the patient dose.
if you decrease distance, you increase patient dose, yes. Right, so like I said earlier, longer SID, bigger distance, reduces magnification, increases spatial resolution, so your image looks better. So we do have two standardized SIDs, like we said, 40 inches and 72 inches. 40 inches is going to be about 100 centimeters. 72 inches is about 180 centimeters. I'm just rounding here. Right? Sometimes you may see something else aside from these. For example, you might see 44 or 48 inches instead of exactly 40 inches. Okay, so just a slight increase in SID here. But generally speaking, we're going to be talking about 40, we're going to be talking about 72.
So when we were in the lab,
Yes.
we would move a certain distance and it would stop at like 58 or 59, and we don't have to worry about that one.
You do not need to worry about those. So yes, in lab, your tube stopped at 125, 72, 59.5, and 40. Do not worry about 125. Do not worry about 59.5. The ones I would like you to focus on are 72 and 40. Be aware that others can exist, but the main ones are going to be these two. Okay, so 44, 45, 48, those could exist. They might be used in place of 40 where you work. But for the purposes of discussion, we're only going to talk about 40 and 72. Right. If a specific SID is not mentioned, use a minimum of 40 inches. Do not go closer than 40 inches. Right. Because as you saw, the closer you get, you have more magnification, you have less resolution, you have more patient dose. So you don't want to get too close to your patient. Besides, 40 inches is already really close to your patient. You'll see that once you start putting a patient in between the tube and the IR at 40 inches, you don't have very much room to work with. Collimation. Collimation is the restriction. Right, is the restriction of your X-ray field. So, your radiation field must be restricted to expose only the anatomy of interest. We only want to give radiation to the part we care about, the part we want to look at. We do not want to give radiation to any other locations. So that is one purpose of collimation. Collimation actually has a second purpose as well. Collimation reduces something called scatter radiation. Scatter radiation is responsible for reducing the quality of your image. It makes your image look foggy. It makes it look lower quality. So by collimating, you make your image look better. You cause your image to have more detail. So collimation is good. You want to collimate as much as possible. It is a violation of the ARRT Code of Ethics. It is a violation of the ASRT practice standards to collimate larger than the required radiation field size. So, for example, if I have my IR here, and what is the name of this IR? It is a PSP, but this is a 10 by 12. It is a 10 by 12, right? If my collimation field, my light, was 14 by 17 when I'm using this, that would be a violation. Why? Because all that extra X-ray will not do anything for the patient. It will not do anything for the image. My image only requires a 10 by 12 collimation size. Anything larger than that, and I am unnecessarily exposing the patient. Can I go smaller than 10 by 12?
Yes, I think so, sir.
Yes. But can I go bigger than 10 by 12?
No.
No.
Because the radiation, patient will be exposed to radiation.
Correct. Patient will be exposed, and that extra radiation does nothing. So it is very important that you do not collimate larger than the required radiation field size. Always collimate as much as possible. Once again, I will warn you, when you go to clinic in the fall, you will see some texts that do not collimate, that say, open it up. I don't want to miss anything, open it up. But that is bad practice. If you have proper positioning, if you are able to put your anatomy in the correct location, you should not need to worry about missing anything. Okay, so make sure that as students you practice proper collimation. Okay, collimator should be manually adjusted so that the field size includes all anatomy pertinent to the radiographic procedure. So make sure you include all anatomy that you care about, leave out the other anatomy you don't care about. These field dimensions, the extent of the collimated field edges in relation to the anatomy, these are included for all radiographic projections and positions included in your marrows. So if you open up your marrows right now, you flip to any chapter, chest chapter, the hand chapter, and you look at the instructions, part of the instructions will be how much to collimate. So you have no excuse for not knowing where your collimation should start and end. Yes?
So an example of that would be like collimator, for an example, collimator inadvertently open to size 14 by 17, or set correctly to 8 by 10. Is that what they're talking about, or?
Sorry, for this here?
I'm just looking up like an example, I guess.
So, let's see. Let's go to 111. So for example, if we go to something like your abdomen chapter here, right, and scroll through to the part where it tells you how to position for your abdomen. Right? As part of it, along with telling you where to put your central ray, along with telling you how to position your patient, there will be a heading that says collimation. And it will tell you what type of collimation to use. Okay, so you can find that in your mirrors. In terms of any procedure, it will tell you that. So, if you take a look here, this is an X-ray which is set up for the patient's shoulder. Between these two images, A and B, which one looks like optimal collimation?
B.
Why?
It's to the side of the thick.
There's an outline on the back as well.
All right, great.
Sorry.
So it's smaller, it's more focused, it doesn't go outside your cassette. If you look over here, right, you see all of this light on the backboard. All of this light exposing stuff would just knock the patient. We look over here. We only have the minimal amount of light here, right? More of our light is focused on the patient compared to here. Right? We've coned in because we only care about this section here. Right? You can't cut off this light because your collimators is rectangle, but we have limited this to only the anatomy necessary. Right? Over here, we're catching the neck, right? We're catching the spine. We don't need all of that on a shoulder X-ray. We only want the shoulder right here. So, B is the more optimal collimation.
For that picture, are
Yes.
they identifying like area in the clavicle, like specifically the head in the shoulder area, or just a humerus? Like, just are you able to tell that based off of like the area of what they're like getting an image for?
Good question. So when you learn these procedures, you will learn that each one is looking for specific anatomy. In order to show that anatomy, each one must be centered to a specific location. So in this case, for the shoulder, you see your crosshair right here? This crosshair is centered at a portion of the shoulder called the coracoid process, specifically 1 inch below the coracoid process. By doing so, you will be able to demonstrate the scapula. You will be able to demonstrate the distal portion of the clavicle. You will be able to demonstrate the proximal humerus. Those are all things that we are going to be looking for in that shoulder X-ray. But we are not looking for the spine, we're not looking for the chin, we're not looking for anything else. So that is why you will collimate to only the area of interest. Show only the things you need to see, and do not show the things you do not need to see.
Thank you.
You're welcome. All right. Shuttering. So nowadays, we have our images show up on computer monitors. Like most images on a computer, you can edit them, right? You can Photoshop your images. So let's say that you were the tech which did this. And you're like, oh no, I have too much stuff on here. Oh, I don't want anyone to find out about this. Let me Photoshop my image so it looks more like that one. Right? I call it Photoshopping, but it's actually a function built into the software called shuttering. You can digitally collimate your image so it only shows the information that is necessary. Is this okay?
I don't think so.
Is this an alternative to using actual collimation?
No,
Seems like-
sir.
It is
It's
not.
It's
Or I meant
unethical.
it's
It's not unethical. It's unethical. Right? It's not
That's right, it is unethical.
unethical.
right? So you cannot use this as an alternative to proper collimation. Why? Because you have already exposed the patient to more radiation than is necessary. Right? And now you've just cut out all that extra information, but the radiation was still used.
So I have a question.
Yes.
But now I've made that mistake by not collimating correctly.
Mm-hmm.
But to get a better image for the radiologist,
Mhm.
is it okay to collimate, or it won't do it to that extent, even if you're photoshopping it?
So yes, you would still end up collimating to send the radiologist a proper looking image. But do not use this as an alternative to collimation. If you make a mistake, right, then sure, right, just bring it back down. If the computer makes a mistake and gives you extra stuff outside, you can bring it back down. But you should not be making a habit out of, well, I'll just fix it afterwards. Right? That should not be your mindset. Some techs go in with that mindset. They'll say, I'll just keep it open, and then if I make sure I see what I need, I'll cut it down. Do not do that. Always try to have proper collimation. Always try to have proper collimation. Yes?
So before, if you fix it afterward, is the focus, or is the image equally good as collimating it from before?
No.
It won't be good,
It
right?
is
This
not-
isn't a photograph.
It is not equally good. As far as image quality goes, you will have more scatter. You will have more fog. Your image will look lower quality even after you shutter your image.
Makes sense.
So a good tech would be able to recognize that, hey, they just shuttered instead of properly collimated.
Right. You can tell because it does look slightly different. Not just the image, but even the borders. On a properly collimated image, the borders will look slightly fuzzy because that is where the x-rays are starting to fall off. On a digitally shuttered image, your borders are going to look super sharp because the computer just cut the image for you. Right? In addition, there is a danger to shuttering because, okay, let's say that you now shutter. You have basically deleted information from your picture. Right? So now the question is, okay, well, you shuttered it. Did you shutter because the collimation was bad, or did you shutter because you're trying to hide something from me? Are you hiding a mistake that you made in the image, and that's why you're shuttering now? Right? So it does create legal issues, it does create ethical issues. So do try to avoid shuttering. How do you do that? Just use proper collimation from the very beginning. Does that make sense? So, patient is overexposed, right? So, that's a problem with shuttering. That's why you want to properly collimate. If you shutter and you cut off important information, and now the doctor misses the diagnosis, you could be liable because you're the one that removed information from the image. Right? So, do try to avoid using shuttering. There's basically only one situation where it is susceptible to shutter. And that is when the computer does not properly process your image, and so you see your image in the middle, and then outside, instead of black, it looks white. Right? And the white area is the part that you try to physically collimate off, but the computer did not recognize it. So in that case, instead of flash bombing your radiologist with a giant white image, you will cut that section out with shuttering. That's pretty much the only allowable situation. Oops. Okay, anatomic markers. Your markers are being ordered right now. You will get them as soon as they come in. The purpose of markers is to indicate which side is left or which side is right. This is important because this is a legal requirement. It is a medical legal mandate that these markers be present. If your image ever needs to be brought up in the court of law, it must have a marker to be legally viable. annotations, putting the marker on digitally after you've taken the image is not recommended because it becomes very easy to put the wrong letter on the wrong side. If you took an x-ray of me, of my neck, right? This way, right? Where would you want to put the left marker?
So towards your left hand, towards your
Towards
left.
my left side, right? Over here. Okay. If you took a picture of my neck from the back, where would you want to put the left marker?
Still on the left side.
Towards your left hand.
Right on my left side. But if you look at a picture of the neck, taking it from the front, taking it from the back, it looks exactly the same. So it becomes very difficult after taking the picture to figure out which side is left, which side is right. That's why you should always mark your images. Always have a physical marker on your images. It doesn't matter how small the anatomy is. It doesn't matter how small your light field is. It doesn't matter how tight your collimation is. Always mark your images. There's always somewhere to put your marker. And we will discuss that in lab. Yes?
Sir, for your fingers, and you don't need a marker.
You do need a
because your
marker.
thumb is there to mark it,
You do need a marker.
even with the
You
fingers.
always use a marker.
If it's upside down.
Besides, if you show a finger, is it the left hand or the right hand?
Mhm.
Right? I don't know which finger it is.
Mm.
The doctor could have ordered the left hand. Maybe you're blind, didn't see it, and needed the right hand. I don't know which finger that is, so you always need a marker. Always. Okay, some examples. Right, left and right markers with initials. Okay, over here, some thicker versions. This is the type you will end up getting. Here we have some fancy markers with BB position indicators. Right, I have one of those fancy markers right here. The balls, the BBs, they're just used to help the radiologist know how the patient was positioned. Right? Patient standing up, the balls are on the bottom. If the patient's laying down, the balls are in the middle. If the patient was on the side, then the balls are on the side.
Okay.
Very convenient.
So how, when a patient is standing up, how would you put a marker, sir?
We will discuss that in lab.
Because that would be the actual thing to recognize, right?
Yes.
The initials are for the technologist or for the health system that they're working for? Or?
Great question. The initials are for you, the technologist. And as students, after your initials, you will have a small s to indicate that you're a student. That way, we can identify who took that image. So if we ever need to go back, we can talk to that person. So if there was an issue with the patient, we can go back to the tech and ask, hey, do you remember this patient that you did, right? These are the images that you shot him done. Okay. So it's a way to identify which tech did which image. Basic marker conventions. Always have at least one marker on your radiographs, either the right marker or the left marker. The marker should never obscure anatomy. So if I'm taking a picture of the head, I should not see the left marker in the middle of the skull. That is going to be an issue if there's a giant L in the middle of the bone. The marker should always be placed in the exposure field on the edge of the collimation border. So you should put the marker out towards the edge of the light field. Don't get it too close to your anatomy. The marker should always be placed outside lead shielding. The reason is because lead shielding makes that part of the image white. You will not be able to see the marker over the lead shielding. And then left and right markers must be used with digital imaging. So it doesn't matter if you can put a marker on afterwards, you need a left or right marker physically on your image, even if it is digital. All right, and so these are some examples of markers. Right, so over here, do you see that marker all the way up here at the top? Right. this, not ideal. Why? Because that is a digital marker.
So because it's not because what, sir?
That looks like a digital marker to me.
I
It
see.
looks like it was put on after the fact.
I see.
On the other hand, here, this is a physical marker. So patient's right foot, right marker here indicating the right foot. Over here, right marker indicating this is the patient's right wrist. Over here, right marker with an arrow indicating that this is the right side of the patient's chest and it is up. The patient is laying on their side, left side down, right side up. So examples of marking your patient.
So if that top right one was done with your BBs, we would be able to see that it had the BBs like towards this and it was oriented this way, or?
Correct.
Okay, cool.
And sir, those two don't have initials, those pictures?
Yes.
It would
If
definitely-
you don't see initials, it's very likely it was a digital marker.
Oh.
Right? So that's the other problem with digital markers. They don't come with initials. You would also need to digitally mark your initials. Right? And of course, what happens if someone's feeling a bit malicious and decides to put your initials on an image, on a Battle King image that they did, right? So you don't want to use digital annotation,
Is there-
physical markers.
Is there any way to disprove that that wasn't you who took that image, or like if someone were to do that
Mhm.
malicious thing that you said?
Tracking.
Track just
So
backtrack.
we use digital tracking to sign patients in and out.
Okay.
We can see who was logged in and who tracked that patient.
So,
All right, it is 10 o'clock, so we'll go ahead and stop here for today, slide 36.